Good afternoon, everyone. Um, Today's case is a young female who acutely presented with palpitations and some chest discomfort. 2 3 weeks ago, the history was or mentioned that the patient experienced epilepsy seizures. The labs showed that there was a raised troponin T and troponin I. Toxicology came back negative. Coronary artery disease was excluded, so normal coronary arteries. Echo showed some mild pericardial effusion as well as mild left ventricular dysfunction. Therefore, the patient was sent for cardiac MRI in order to investigate further of any underlying differential diagnosis of the cause of the cardiomyopathy. As we mentioned earlier in the basics of cardiac MRI, this is a two-chamber view, left atrium, left ventricle, and the function here is mildly impaired. In a 16 years or young patients, we would expect better systolic function. The systolic function here was estimated 45%. Moving to the four-chamber view, again, left ventricle, left atrium, right ventricle. As you may see here, again, mildly impaired left ventricular systolic function, and the left ventricle wasn't dilated, but as you may see here, this mild pericardial effusion. And moving toward the maps, first we'll start with the T1 map. And the maps, the idea of the maps are they are more sensitive rather than specific. The T1 map is a kind of logarithmic representation of the T1 relaxation time of the myocardium. The same slice acquisition is around 11 times, and then the software will create a map by interpolation of pixel by pixel and measuring the relaxation time of the T1 map in this pixel. On 1.5 Tesla, you would expect a normal ratio between 970 to 1100. It depends on the vendor. So for example, here in this case, it was 1300 on 1.5 Tesla, which indicates that it's elevated. And not only in the septum, but it was elevated everywhere, which means that there was a kind of diffuse interstitial changes. So the T1 map could tell us that there is diffuse interstitial changes by deposition of abnormal material within the myocardium or within the interstitium. This is the native T1. If the signal was below the 950, then you would expect that the changes are not in the interstitium but intracellular. For example, in other diseases like iron deposition and so on. So this are the uses or a kind of a hint about the uses of the T1 maps. So we three-chamber view, normal mitral valve, normal aortic valve, again mildly impaired left ventricular systolic function. And this is another sequence, it's the T2 map, where it could represent, or it represents the T2 relaxation time of the myocardium. On a 1.5 Tesla, usually the normal range is going to be between the 55 and 60 millisecond as the T2 time. Again, here was elevated, and the elevation was not in one territory but in multiple territories. Which again confirm what we saw on the T1 map, but here in the T2 is kind of sensitive to edema. So we could conclude that the changes that we saw on T1 map was because of the edema, or maybe part of it is because of the edema. Moving towards RVOT showed that there is intact pulmonary valve. Early enhancement, that is 1 minute after giving the contrast injection. This is an inversion recovery sequence in order to null the myocardium and then take some pictures 1 minute after giving the contrast represent the early enhancement, and 7 minutes and 7 minutes plus represents the late enhancement. Early enhancement usually used to detect any possible MVOs or mural thrombi or intracardiac thrombi, which would be a dark signal because of lack of enhancement. But as you may see here, all this homogeneous myocardium, which means there was no intracardiac thrombus and there is no mural thrombus, there is no mural MVO. And those are the different views of the early enhancement. Short axis view showed again the mildly impaired function. Left ventricle was not dilated. Mild pericardial effusion. LVOT intact. And this is the scout that we do before the acquisition of the late enhancement. As you may see, the nulling point, because this is an inversion recovery sequence, so every tissue has an inversion time different. So the blood usually, or it should be that the blood nulling point is different than the myocardium. Blood is before the myocardium, and then we check for the inversion point of the myocardium, and then we would perform the late enhancement. I'll go to the short axis because the short axis views are much better than the other views. So this is short axis going from the apex toward the base, and as you may see from the apex along the lateral wall, enhancement in the subepicardial layer, again along the posterior wall in the subepicardial, again posterior or infralateral wall toward the mid ventricle, and along the lateral wall in the basal cuts. And in the cardiomyopathy, presence of edema means acute event or itis, inflammation, active inflammation, together with subepicardial enhancement. This pattern is very suspicious of myocarditis or an inflammatory process in the myocardium. Together with the edema, this of course makes the myocarditis or inflammation of the myocardium on the top differential diagnosis. So this pattern of subepi and usually on the lateral wall is diagnostic of myocarditis in such acute event. Thank you very much.